we can do to be as healthy as we can be and to be examples to not only our children, but to our neighbors, our friends, our church members. So we have to get involved, and the first way that we can do that is to become more knowledgeable about what's out there, what's available to us, and what we need to do to better care for our own selves. So again, I'm going to say it's colon cancer awareness that we're talking about today. So we're going to talk a little bit about colon cancer. Let me tell you what colon or colorectal, either name is technically correct, but what colorectal cancer is, it's a cancer that starts in either the large intestine or the rectum. It's a very, very easy cancer to screen for and to treat, but what happens is that many times we don't get screened, so we don't know that we have it, and then it sits there and manifests and becomes worse than it needs to be. Again, colorectal cancer occurs in the large intestine or the rectum, and usually what we find first is what we call a cancerous growth or precancerous growth called a polyp, P-O-L-Y-P. A polyp grows in the lining of the intestine or the rectum, and that when that polyp grows, it's non-cancerous, so it doesn't hurt us. But what happens is, as it sits there over time, it can turn into a cancerous lesion, and therefore we would develop colon cancer. So there are some easy things that we really can do to screen for colon cancer, and it's really lately been talked about a lot in the news, and we've saw people on TV actually doing some of the screening tests. Let me tell you when it's important to be screened. First of all, if you are over the age of 50, you are a candidate for screening. So those of you out there who have not turned 50 yet, don't be shouting or celebrating too fast. Because if you live in my community or you look like me, or African American, you should be screened even if you're younger than 50 years old. I know so many weeks I come here and we talk about the things that disproportionately affect our community. Colon cancer is one of those. So if you're 50 years old, you should be screened for colon cancer. If you're younger than 50 and you are African American or you look like me, you should be screened. Also, if you have parents or siblings, your brothers, your sisters, or children who have been found to have these precancerous lesions, these polyps, you should also be screened because it has a familial tendency or genetic predisposition. If you are out there and you suffer from some of the various digestive system diseases, you should be screened. Some of those digestive system diseases are ulcerative colitis, you may have heard of that, or Crohn's disease. Oh, welcome. Here's my guest. Come on in, make yourself comfortable. I'll give you a few minutes to get settled. We're very informal here, so we're just happy to have you. If you have any of the digestive system diseases, you should be screened. A lot of people suffer from what we call a catch-all kind of category, IBS. I'd say if you suffer from IBS or irritable bowel syndrome, you should also speak with your physician and be screened for colon cancer. I'm going to turn around now and introduce my guest to you. Today my guest is Dr. Vicki Henderson. She's from People's Community Health Clinic. Welcome, Vicki. We're happy to have you.
Thank you. Thank you so much.
Yes. So I'm going to back Vicki, and I'm going to have you tell us a little bit about yourself, who you are, what you do at People's Clinic, when you came to this community. Tell us a little bit about your family, too.
Okay, well, I moved to the Waterloo area in 2010, I guess it was, and started working at People's Clinic just about 3 years ago. And I'm a primary care physician there. I see mostly adult patients, but sometimes I work in the urgent care and see children there as well. And mostly I have a panel of patients that I see and take care of, and people of all ages. So I work in Waterloo, but I live in Denver. My husband's a pastor, and we ended up moving to the area because my husband got a job here.
Well, we're glad he did, because that brought you to us to care for more of us in this bit about your family. I heard you say that you and your husband live in Denver. Do you have any children?
I do. I have 3 children, 3 teenagers, so it's
challenging.
a busy, challenging time in our house.
I have a teenager myself, so I understand. She's my baby girl, my last one, but a challenge. She just started driving to school, so I'm all aware of those challenges. I had to follow her the first day. In fact, I was pretty nervous, but after that, I kind of relented and let her go on her own. Again, welcome to you and your family, and we're really happy to hear that you're at People's Community Health Clinic, because People's does a lot of service for families in need in this area, so thank you again.
Oh, you're welcome.
So, we're going to talk about colon cancer. So, I just began a little bit by sharing a little bit about what it is. I'm going to let you do the same thing. Tell us a little bit about colon cancer and what you want us to know.
Well, colon cancer screening is recommended for anybody over the age of 50. Under the age of 50 if there's a family history of colon cancer, but colon cancer is often not recognized. So it's not often something that you have symptoms with. Mm-hmm. And so that's why screening is important. Mm-hmm. And so we screen several ways. Just the testing for blood in the stool can be a sign of colon cancer. And so yearly test for blood in the stool after age 50 is recommended. Mm-hmm. And then a colonoscopy is recommended after the age of 50. Mm-hmm. Screening. And that's a way to directly look at the inside of the colon, and the doctor that's doing that can take biopsies and things if need be, if they see something that looks abnormal. Mm-hmm.
And that's right, because every aspect of our body teaches us something about our health. And so actually, when you said that you would take the samples looking for blood, that would tell us if something was going on in there to investigate further. And I just had mentioned before you came on that the new screening for the colon cancer screening, I can't think of the name of it now, the scope, it's become really popular. We've even seen it on TV. Several people on the Today Show have volunteered to do that just to show us the ease of it. In fact, most people, being a nurse, most of my patients say that the prep is actually much worse than the procedure itself.
Yes, much worse than the procedure itself. So the procedure they give anesthesia for and medication so you don't remember the procedure. Yeah. So the procedure itself is not a problem.
Right. So let's talk a little bit about the prep so people know what to expect, because when you have a scope inside of your intestines, of course we need to be able to visualize that. So the prep would be necessary to remove all matter so that we could actually see it.
Absolutely, absolutely. And so depending on who the doctor is that's going to do the scope, they may have different preps, mm-hmm. but essentially that's just to clean the colon out. Mm-hmm. And so the day before the scope is done, they're going to say you can only have clear liquids mm-hmm. that day, and that's because we don't want to add any more fecal material to the colon. We want to get rid of what's there. And then they give medication to drink that's going to keep things moving and get things moving out of the colon. So you want the colon to be nice and clean mm-hmm. so that it can be directly visualized. If there's any fecal material left in the colon, they won't be able to see the walls of the colon, which is what they need to see in order to screen for colon cancer.
That's right. So the prep usually takes a couple days.
Right, right. Depending on who you're seeing, 1 to 2 days.
Right, okay. And then so that morning we arrive bright and early at the hospital for the actual procedure. And most people are given some medicine, like you said, that helps them sleep, and they actually don't remember the procedure at all.
They give them medicine that helps them relax, and medicine that actually kind of takes the memory away. Mm-hmm. So it's something we call conscious sedation. Mm-hmm. So you're not completely asleep. They don't mm-hmm. They don't put you on a machine and have breathing done for you, but they monitor you very closely. And you're awake, and a lot of times you can be interacting with the doctor during that procedure, but you're usually not going to remember that at all.
Yeah. And then afterwards you'll come out. It's a relatively quick procedure. Mm-hmm. Like I said, some people have stayed awake and remembered, like the Today Show staff. But then you come out, and a lot of people in that period, I know patients that I've taken care of before. They wake up and they ask me questions, and then they fall back to sleep, and they wake up again and say, what time am I going to have my procedure? And I'm like, you're done. And they're like, no, I didn't do it yet. And so then afterwards, you just have to eat something, drink something, and soon you're home. So it's a relatively quick procedure done in ambulatory surgery. Tell us about what you're looking for in that procedure, Dr. Henderson.
So the thing that the specialist is looking for are polyps. So there are several types of colon polyps. Some of the colon polyps are more likely to turn to colon cancer. So there's a specific type of colon polyp called a tubular adenoma. And we can't tell which types of polyps just by looking at them with the colonoscope are going to turn to cancer. So the doctor that's doing the procedure will actually try to remove the polyp, and then he sends it to the pathologist where they look at it under the microscope, and they're looking for this specific type of polyp that we know is predisposed to colon cancer. If a person has those types of polyps, they may have to repeat the procedure within 3 to 5 years. These polyps are slow growing, but we do know that there's a potential to turn to colon cancer. And so we want to get that before it goes to colon cancer and before there has to be any drastic treatment.
Right. And so when you remove the polyps, they will not grow back for that period of 3 to 5 years. They'll still be small, and there's a relatively low risk afterwards.
Exactly.
And then the patient will repeat that testing procedure every 3 to 5 years thereafter?
Right, unless they perhaps they have colon polyps in 3 years, they're checked again, they don't have colon polyps, then the doctor may say, well, we're going to go 5 years this time. But the usual screening time is 10 years. So if you're at age 50, you have a colonoscopy, and you don't have any of these bad colon polyps, and you don't have any family history of colon cancer, the doctor may say you're good for 10 years. So.
And so are some polyps that may grow that never turn into cancer?
Yes.
Do we remove those also? Because
Yes.
we test them all.
We test them all because just by looking at them with our eye, we can't tell which kind is which kind.
Right.
So.
All right. Okay. And then is there something we can do after that initial screening to decrease our risk of developing colon cancer? Share a little bit with us about what that is.
So, absolutely. So, stopping smoking. Smoking is associated with all kinds of cancers, so cutting out smoking is helpful. And weight loss, eating a high fiber diet, helps prevent these things. So.
Wonderful, wonderful. Does increasing the fluid to help push all that stuff through, does that also help out?
Oh, absolutely, absolutely. So anything you can do, to avoid constipation. There are other colon diseases, so diverticulitis or diverticulosis, and if you have chronic issues with constipation, you may develop those kind of things. And so to keep regular bowel movements is always beneficial to the colon health.
Very good. So that brings me to my next question. Many times I know with colon cancer there are no signs and symptoms. But sometimes we do have a few. Can you share with us what some of the things that if patients notice, they should be alert to go begin to see their doctor and ask questions?
So the first thing, and the big one that we think about is blood in the stool. So if you see any blood in your stool, that's an abnormal thing, and that should be investigated further. Not all colon cancers bleed, and not all bleeding from the colon is colon cancer, but that's a sign and symptom that we definitely would want to check out. And if you haven't had a colonoscopy, you probably would be advised to have one at that point.
Right. And sometimes it's not bright red blood that you're looking for, because a lot of times patients will miss it because they're looking for bright red blood.
Right.
And oftentimes when things go through the digestive tract, we don't see bright red anymore. So tell us a little bit about what it will look like.
So blood, it can be bright red. And bright red blood is usually an indication it's coming from lower in the digestive tract. Often it's black. The stools will turn a very dark black. And that's a sign that it could be blood could be coming from higher in the digestive tract. And so that's definitely something that should be checked out. And then the other thing is a change in bowel movements. So especially if your bowel movements have been normal in normal size and then all of a sudden they're very small, that's something that should be checked out. And then sometimes abdominal pain can be a sign of developing colon cancer. Abdominal pain, recurrent vomiting. So the colon cancer could grow, so it could block the intestine, and that could be a sign.
Okay, so I heard bright red blood, the dark tarry stools, or the dark stools, which would be the digestive blood, belly pain for no clear reason, usually in the lower half of the belly, what you say, Doc? Okay. And then what about if you're feeling it's blocked and you're feeling like you're unable to go?
Oh, yes.
Yeah. Any change in bowel habits. Okay. And then a person who may be losing weight and unintentionally not trying to, feeling like they're still eating the same, but unintentionally having weight loss.
Right.
Will be another reason they should be checked out. Okay, that's good. So, so we know when we should get screened. We know the signs and symptoms that we should look for to report to our doctor. What can we do to eat healthier to help to prevent it? I know you said whole grains. Anything else specific?
So just anything with increased fiber. So fresh fruits and vegetables. Okay. I don't think any of us in the United States get enough of that in our diet. We really need to push that in our diet. That really improves the colon's health. Just the colon works to digest those and push those through, and it helps keep the colon healthy.
So listening audience, you hear that, and it's supposed to be spring. I know there's lots of snow out there right now. It's supposed to be spring, so it won't be long before the farmers will be planting, and we'll have the farmers market, and we'll have all these fruits and vegetables, and we should be really, really doing those because that roughage in our diet is good for us. What about activity, doctor?
Absolutely. So activity helps to keep the colon moving. So a lot of times people that have chronic constipation, one of the things we do is try to get them moving. A lot of people who may have had surgery in the past kind of know that the doctors are kind of pushing them in the hospital to get up and walk, and that's part of the reason, because just walking and the movement helps our colon move naturally. So that's absolutely important.
Yeah, very, very good. So, Doc, I think we've pretty much covered most things about colon health. Smoking is a risk factor. I'm repeating it for our listening audience out there, smoking is a risk factor. It can contribute to many different kinds of cancers. If you have a family history of colon cancer, you should be screened. If you are over the age of 50, everybody should be screened. But if you have a family history, or you're African American, or you have other digestive system diseases, you should be screened for colon cancer. If you have any changes in your bowel or habits at all, whether it would be blood in your bowel, or belly pain, or very watery diarrhea, or the inability to go, feeling very, very constipated, all of those are reasons that you should go to your doctor and have your self checked out to see. Some things that you can do to help is, again, increase your fruits and vegetables because they are high in fiber. Your whole grains are really good, low-fat diet, and let's move a lot. Let's get to moving, and that movement does not have to be in 30 minutes at a time. You can break it up and do 10 minutes 3 times a day, but let's get moving. I always have a famous joke that I'd like to lose 40 pounds by tomorrow, Doc. It hadn't happened yet. Hadn't happened yet, but hey, keep hope alive. I also heard that there's going to be some colon cancer screening kits that are going to be available. Can you tell us a little bit about that?
Yes, so we're going to have some colon cancer screening kits that are going to be available at People's Clinic. They can be picked up Wednesday and Thursday, March 26th and 27th, from 9 in the morning till 7 at night. These are screening for basically blood in the stool. So sometimes there can be blood in the stool and you can't see it.
So tell us a little bit about how those screening tests work, Doc, because that sounds relatively easy, but let's go ahead and talk about the procedure so when patients pick it up, they know what to do.
Yeah, so it's just a card or a tube, and when you have a bowel movement, you just take a small amount of your bowel movement and you put it on this, and then you bring it back in for testing.
That's right, and then that gives the doctor a picture of your health so that she can better diagnose what's going on or order some further diagnostic testing to see what's going on, what do we need to do to get your health where it needs to be. So again, those kits are going to be available Wednesday and Thursday, March 26th and 27th at People's Clinic. Do we just come into the front desk and pick those up?
Yes, I believe so.
Yep, and it's walk-in. We don't need an appointment. These are specifically for people who are over the age of 50, about 50 to 64, people who may not have health insurance or who may feel inadequately insured can come right on in. And then this screening is hosted in cooperation with the Iowa Department of Public Health, the Black Hawk County Health Department, People's Community Health Clinic, the American Cancer Society, the Iowa Cancer Consortium, Wheaton Franciscan Healthcare, and Covenant Clinic gastroenterologist Dr. Mucha and Dr. Gwander. Now, if I messed up anybody's name, please forgive. Mojica. Is that how you say it, Mojica? That's nice. Okay, Doc, so we did a little bit talking about colon cancer. Tell us a little bit about what else you'd like to talk about today.
Well, you put me on the spot.
Because there are lots of things that we can do to take better charge of our health care.
Well, when I think the diet issue is kind of a big thing. We touched on it a little bit with the colon cancer, but obesity is such a big issue in the United States right now. We have just such a high-fat diet, and trying to be aware of what we put in our body. And I know our lives are busy, and I have 3 teenagers, so I'm often eating on the run, and there's a lot of temptation for bad eating out there. So being aware of what we're putting in our body, and trying to if we can't exercise every day, trying to park at the end of the parking lot and walk that little extra distance to get into wherever we're going, so we can get extra activity in our days. I think our days are often just so sedentary, and then we're often eating junk because we're busy.
Yeah, we are busy. Back in my great-grandmother's time, they worked the farm, and Grandma stayed at home, and she had all of the meals ready, so the family ate a lot healthier. And now we have 2-parent families with both parents working long hours. The kids are all in school, so we don't have the same dinner habits that we used to have. A lot of times it's the more quick stuff. I know the other night I was ordering pizzas, and everybody wants a different kind of pizza, so let's order everybody what they want. So we're ordering pizza, and dinner is pizza, pasta, and salad. Probably not the healthiest dinner, but sometimes when you're on the move, it works. And we begin to see some of that in the obesity epidemic that we see us facing in the nation right now, not just in us old folks, but in our children. In our children as well, which predisposes them for a lot of health problems.
Absolutely, and diabetes is really on the rise in young children. So I think it's something we really need to promote. We need to promote it for our kids' health. The complications of diabetes can be devastating, and so to see some of these teenagers, young kids getting diabetes is just, it's awful for me to see, because I know I've seen the complications as people get older, and it can be sad.
And the longer you have it, the worse complications you can sometimes get, especially if it's poorly controlled.
Absolutely.
Yeah. And we know that diabetes disproportionately affects minority communities.
Absolutely.
Yeah, so again, that's why eating healthy and getting back out again to our farmers markets and growing some of our own foods is really healthy for us. Maybe if I started getting to the farmers market, I'd be able to get started on this 40 pounds overnight. But, you know, I got to keep trying, keep hope alive.
I don't know, the snow has to melt first.
Yeah, and it's coming. It's trying. Doc, can you tell me, do you know why African Americans suffer more from colorectal cancers than other groups?
No, I don't know why.
We haven't determined that link either yet. I don't know, and I was trying to do a little research on that. And I know that we do, but I'm not exactly sure why. A lot of times we can go back to our history and say that many times we did not have the best food to eat, and that may have led to some of it, but we don't know. We just know that we suffer more, so we have to be more involved in our health care. We have to know what the risk factors are. We have to know what our family histories are, listening audience, so that we can get screened, we can know how to be healthy, we can know how to increase our healthy behaviors and decrease our risky behaviors so that we can get healthier. We're going to prepare for a break. We've been talking today with my guest, Dr. Vicki Henderson. She is a practicing physician at People's Community Health Clinic, and we're going to be right back with her.
Hi, this is Morgan Freeman.
I didn't think we'd get done talking through all that, so we got to figure out what we're going to talk about for the next half an hour. What would you like? I'll let you take the lead because I don't want to talk about something you don't want to talk about.
Colorectal cancer is the second leading cancer killer of men and women over 50. Since it doesn't always
Let's
cause
talk about
symptoms.
diabetes. Let's talk about type 1 and type 2.
Yeah.
Discuss that. Talk about exercise. Okay, we can do that.
Screening can find precancerous
It's a huge problem, and people are very familiar with diabetes, and that's always a good topic to talk about. Anything else you guys
Screening
think?
can find colorectal cancer at an early stage. And the chances
Well, the other
of
thing I'm always
are
harping on
very
people
high.
about getting tests
Talk
is
with
to
your
get their
doctor.
mammograms.
And get tested for
That's a good one,
colorectal cancer.
too. That's a good
Medicare
one.
and many insurance plans help pay for screening.
I think we can
Get
keep a
screened.
half an hour busy with
Make
that.
sure you are.
Thank you for coming.
Oh, no problem, I'm sorry I was
From the
late.
U.S. Department of Health and Human Services and the Centers for Disease Control and Prevention.
Okay, good afternoon. Welcome back to our show, The More You Know Show on KBBG FM 88.1. I'm still your hostess, Doreen Mingo, and I'm here with my guest today, Dr. Vicki Henderson from People's Community Health Clinic. And we've been talking today, it's Colon Cancer Awareness Month this month, March. And so we've been talking today about colon cancer and really what it is, that it is a cancer of the large intestine or the rectum. We've been talking about how you screen for it and when you need to be screened if you are over the age of 50, if you are African American, because we suffer disproportionate numbers of colon cancer. If you have a close family member, a parent, a sibling, a child who has had these precancerous polyps, you should also probably be screened. Also, if you suffer from any of the digestive diseases like ulcerative colitis, we hear a lot more about that lately, or Crohn's disease, or even if you suffer IBS. I like to think of IBS as kind of a catch-all term when you're having abdominal problems and we can't quite put our finger on what it is. If you suffer from any of those and you're under the age of 50, you should be screened. If you're over the age of 50, and I know that covers a lot of y'all out there because I remember y'all are older than me. I haven't quite reached 50, but I'm praying to get there, Doc. And actually, I'm praying to double that. So I just want to be independent in that. But if you're over the age of 50, then you should be screened anyway, regardless. We talked about some of the signs and symptoms, and I can sum those up to say if you have a change in your bowel habits, if there's a change in your poop at all, then you should be talking to your doctor about that and getting to the bottom of what's going on. Because colon cancer is actually really easily treated, well, aggressively treated, if it's caught early, correct, Doc?
If it's caught early. Yeah,
if it's
so
quarterly.
that's the key. So, and that's why we push the screening.
Yeah.
So, yeah, so it's very important to be quarterly, and a lot of times we can catch it in the precancerous stage.
That's
so these
right.
precancerous polyps, they can just be removed without a surgery, you know.
That's right. And some of the reason that we suffer some of the highest health disparities, and we see that our numbers and everything are increasing, is because we're not always first at the table. So let's get screened. Let's pick up some of these free colon cancer screening kits that are available at the People's Community Health Clinic on Thursday, March 26th and 27th. That will be Thursday and Friday.
No, Wednesday and Thursday.
Wednesday and Thursday, I'm sorry. And they'll be available all day from 9 a.m. to 7 p.m. So it doesn't matter if you work first or second shift, you have time to get there. Let's get screened. Let's be in charge of our health care. Doc, so we've pretty much really covered the colon cancer. We've talked a lot about that. If we have any listeners out there who have a question, you can feel welcome to call in. We'd be happy to help you. But we're going to move on and talk about something else. Let's talk about another disparity that disproportionately affects my community, the African American community, and that is diabetes. Doctor, can you give us a brief overview of what diabetes is? Tell us about both type 1 and type 2.
Sure. So diabetes really is a body's inability to handle the sugar that it produces. So type 1 diabetes is usually developed in someone much younger. And basically the pancreas, which is the organ that produces insulin, just stops producing insulin. So if a person is a type 1 diabetic, they will go on insulin shots right away. Type 2 diabetes is the diabetes that we're really seeing an epidemic of. And that really has to do with what we call insulin resistance. So the pancreas works in somebody with type 2 diabetes, but it just keeps putting out insulin, and the person that has that is just not sensitive to the insulin that the pancreas is producing. So a lot of times type 2 diabetes can be treated with pills initially. It may eventually have to go to insulin if we can't get it controlled with pills.
And in my community, you all know out there that we talk about diabetes. In the olden days, we called it sugar. So if you have a client who looks like me, they may say they come in to talk to you about their sugar. I'm sure you've heard that.
They tell me that.
They do. And so in type 1 or type 2, it's the inability to produce insulin or producing ineffective insulin or not enough
Correct.
insulin that treats, that is able to take care of your blood sugars. And then again, one of the problems that people don't seem to understand is with these high blood sugars, the body does not function as well because the blood is too sweet, too sticky, and it's not providing the nourishment that it should. Tell us a little bit, Doc, about some of the damage, the resultant damage that we can see from people who have had long-term uncontrolled diabetes.
Right. So the damage can be widespread throughout the body, so it affects many organs. So it affects the eyes, and it actually the small arteries in the back of the eye can get plugged by these sugars being high, and it can cause bleeding into the retina and can cause blindness. It's one of the leading causes of blindness in the world.
And it is.
And so it's always very important that anybody who has diabetes at least gets a yearly eye exam, to have the back of the eyes checked, even if the diabetes has been controlled. Because if you've had diabetes for a lot of years, you could still have some of these changes. And changes that, again, if are caught early, can be treated.
Because it still affects that vasculature of those eyes. You can get some leaky vessels and things, yes. And then another thing, people with diabetes sometimes will notice that they have to get frequent prescription changes in their glasses because their prescriptions just don't seem to work as well for as long.
Yes, and you will see, especially if your sugars are high, the sugar doesn't only go into the blood system, it goes into the liquid that's in the eye. And so a lot of times if you have diabetes, and all of a sudden your vision has changed,
Mhm.
it could be a sign that your sugars are higher. So it's something you definitely want to look into, see your physician or be checking your sugars to know what they're doing.
Very good. Another problem we have is the diabetic neuropathies. Can you tell us a little bit about those?
Diabetic neuropathy, again, it's related to small blood vessels that feed the nerves. Neuropathy has to do with nerves.
Mhm.
And so people will get either they can't feel their feet or fingers, or they'll have pain in their feet or fingers. It's often described as a burning type of pain. A lot of people will have that at night.
Mhm.
The pain and the burning or numbness in the feet is not a problem in and of itself. But the problem comes that somebody can't feel their feet, and then they may step on a tack or something on the carpet if they're walking barefoot in their house, and not realize that they've got that in their foot.
Mhm.
And just because they're diabetic, they're more prone to develop infection.
Mhm.
So if they're not checking their feet and they've got neuropathy, they're real prone to get sores and things. And diabetics don't heal
Mhm.
as well.
Again,
as
because of the
somebody who's
sweet, the sugar in the blood.
So, you may have known people that have
Mhm.
had to have parts of their feet amputated, and
Mhm.
that's a reason, because these things don't heal as well, and the vessels just don't work as well in the feet in somebody who has neuropathy.
So let me just reiterate again for my listening audience. Diabetic neuropathy, sometimes you will not wear shoes. Diabetics should always wear soled shoes.
Absolutely.
And you'll get an injury to your foot, step on a thumbtack, bump it up against the bed, split the nail, something, and that sore is up underneath the foot where it's not easily seen, or between the toes, and it's not felt because of these diabetic neuropathies. An infection develops. That infection is allowed to progress because you can't see it, you can't feel it, and our body tells us things by sensations and by the way it feels, by the way it feels and by what we see. And if you can't see it or you can't feel it, a lot of times diabetics won't know. So a lot of times by the time we find that sore, it has progressed so much that often we can't stop it. And so we will see some amputations or some more problematic things when they present. So we've had the changes in your eyes that occur because of our diabetes that have been out of whack for a long time. We have the diabetic neuropathies that occur because of diabetes that has been out of range for a long time. And then we have, the kidney disease. Let's talk about the end organ damage.
Sure. So again, it has to do with small vessels getting blocked by these sugars being out of control, and the kidneys are basically, it's all made up of small vessels. The kidneys are small vessels that filter our blood and get rid of waste products. And so these things the small vessels get blocked up and causes damage to the kidneys. It causes the kidneys to leak protein. And so over time, it can get to the point where you go into kidney failure. So it's one of the number one causes of kidney failure, people going on dialysis because of diabetes being below control. And dialysis is a kind of a big deal. It's
a big deal.
It's a big time commitment, and it's a hard thing to deal with over time. So.
It is. And people are really tired after dialysis. They're really tired. So 3 things that we've talked about that are some of the main sequelae or problems that occur as a result of diabetes in our community that has been out of range for a long time, or high blood sugars that we've not kept in the recommended control ranges. And those are problems with our eyes, problems with our feet, amputations, and problems with our kidneys, leading to end-stage renal failure and the need to be placed on dialysis. And the purpose of dialysis, again, is to clean the blood. The job that the kidneys did do and are no longer able to do because of the damage there. So Doc, we've talked about, and I kind of jumped ahead because I kind of like to show the picture of what happens when you have diabetes, but let's go back to...
I just want to interrupt and say
Okay.
one more thing about
Okay.
complications of diabetes that's
Okay.
often overlooked is the heart.
Oh, okay, good.
So, so diabetics are much more prone to heart disease, to have coronary artery disease, to develop heart attacks, and again, keeping the sugars under control. If you keep your sugars under control, you're less likely to have blockages of those small vessels that feed the heart muscle. And so, so you know, we keep our heart healthy, keep our eyes healthy, keep our kidneys healthy, keep our feet healthy.
That's
So-
right. That's right. And by coronary artery disease, Doc, you mean? Go ahead and tell them.
Coronary artery disease is a heart disease that leads to heart attacks. So, and I know we all have friends and family that have had heart attacks, but it can be quite debilitating. So people can end up with congestive heart failure, difficulty breathing, fluid in their lungs, those kind of things, if the heart is damaged from having a heart attack. And a heart attack basically is blockage of one of the arteries that causes damage to the heart muscle.
Very good. So now we've seen some of the major factors or things that can happen as a result of diabetes. So often we say diabetes, and I think we talk about it and we become immune to it because it's so common, and we really don't see, especially in my community, the damage that it does. So just by looking at those 4 areas, the vision, the kidneys, the diabetic neuropathies to the hands and feet, and then the damage done to the heart muscle, that we can better see why it is so important to prevent diabetes or to control it once you have it. So let's go back, Doc. We know what it is. It is a disorder of the pancreas where we either do not produce enough insulin, where we either produce no insulin, we don't produce enough insulin, or we have the incidence of insulin resistance where the insulin that we are producing is not working well to keep the glucose out of our bloodstream to get it to the cell where it can be used for energy. Let's talk about what puts us at risk for the development of diabetes in the beginning that would lead to some of the sequelae that we talk about.
Sure. So for type 1 diabetes, the type that usually children get, we don't really know what causes that.
Right.
So there may be no diabetes in someone's family and they end up with diabetes as a young person. The other type of diabetes, the type 2 diabetes, the much more common type of diabetes, family history is a big one.
Right.
Obesity, that's a big one. And then African Americans, American Indians are much more prone to diabetes. And I think part of that has been shown because of diet issues and just not being, I don't know that we were meant to eat the diet that we are eating.
Right,
now,
right.
so.
Right. But sure does taste good. Which thus leads us back to the problematic behavior. So we say those are some of the things that put us at risk of diabetes. Definitely in our community, we need to know that. If you have a family history, if you're eating if you're eating a diet that's not healthy, those things predispose us to the development of diabetes. Obesity is probably one of the biggest ones that puts us at risk because we have more tissues that we're trying to get glucose out of the bloodstream and into the cell to be used, and it's not working well, and it predisposes us. Another thing, Doc, that I want to talk about is some of the classic signs and symptoms that one can look for. Let me back up a minute. I want to also say on that as we get older, age in and of itself, increasing age, is a risk factor for the development of diabetes. And we often miss that one, but as you get older, you get more prone to it. So you need to have good habits now. And we always want to tell people also that you can change your habits at any time and improve your health.
Absolutely.
Yeah, so you can decrease your risk factors at any time. So just because I say increasing age is a risk factor doesn't mean that you might as well go on and just do whatever you want to do. because you can be healthy at an old age too. Doc, let's talk about some of the classic signs and symptoms that one would need to watch for to indicate that they might have a problem with high blood sugars.
Sure. So we already talked about when and now that's a vision change.
Yes.
A sudden vision change. But often a new diabetic that comes into my clinic will say, "Hey doc, I'm up all night peeing. I'm urinating every hour, every 2 hours through the night." And so that's really kind of a classic sign. And so if you're having an issue like that, you definitely need to be checked out. The other thing is I'm always thirsty. I can't get enough to drink. I'm constantly drinking. Wounds or cuts that don't heal can be a sign of diabetes. So you get scratched by a cat. It takes 4 weeks to heal that scratch up.
Right.
That might be a sign that you need to be checked out. Can't get enough to eat. Every fast food restaurant I stop at, I have to eat. I'm up in the middle of the night eating. That's another sign. And weight loss, sudden, not necessarily sudden, but weight loss over time, unintentional weight loss,
Right.
Can be a definite sign of diabetes.
So let's go over those again. Some of the classic signs: polyphagia, eating all the time. You know you're not hungry because you just ate, but for some reason you have the desire to eat. You just want to keep eating. Polydipsia, that's always thirsty. The classic sign, always wanting something to drink. And then polyuria, which is the always having to go to the bathroom. You're going to the bathroom every hour faster than your body normally would produce urine. So those are the 3 classic signs that you'll hear people talk about all the time: the increased thirst, increased urination, and increased hunger. And then the other 2 signs Doctor mentioned were the sores that will not heal or that take an abnormally long time to heal, as opposed to what you're used to. And then vision changes, finding that your glasses just don't seem to work for long. And so those are the things that you need to watch for. And if you see changes in those, you need to report to your doctor. But just knowing that if you have that family history, if you are obese, you're going to be predisposed to be at risk for some of those things also.
Absolutely, and you should be checked. Yearly. You should have your sugar checked if you've got a family history of diabetes or you're overweight. You should be checked and have your sugar checked at least once a year at your annual physical.
And a lot of times we'll have health fairs or health screenings throughout the community, and I recommend that every time you have an opportunity, even if it's just to get your blood pressure checked at the machine at CVS, go ahead and sit down and check your blood pressure and write it down, because you look at it right then, but you need to have something to compare it to over time. So do the same thing for your blood sugars.
Absolutely, that writing it down is
Yeah.
key, and especially if you are a diabetic and you're taking your sugars, you need to write it down and bring that log of your sugars to your doctor's appointment, because it's hard to adjust your medications without that log of sugars. It makes the job more difficult for your doctor.
And then I'm just going to chime in here, Doc, because I know some of my friends and my family and the members in my community. You also have to be very honest with Doc when you get there. We want to seem like we're doing the right thing. Are you eating 3 meals a day? Are you eating 3 snacks? Yes, Doc. Are you taking your insulin 3 times a day? You have to tell Doc what's going on so that as she looks at the picture of your blood sugars and what they've been doing, she'll know where to make adjustments. If you're telling me that you're eating 3 meals a day, but really you're not getting up every day until noon, so you're not having that morning insulin with breakfast, and we're not knowing what your blood sugar was fasting in the morning, it's very difficult for a doctor to get you under good control and keep you there if she doesn't have a realistic picture of what you're really doing. Am I right, Doc?
Absolutely.
So we got to be honest, we got to tell the truth, and we got to try to adhere. I hate the word non-compliant, but we have to try to adhere. And then what I tell my peers, those of us who are nurses or who are teaching young nurses is to tell them, again, we have to remember to tailor interventions so that patients can adhere to treatments. If you come into my home and you totally change my cultural cooking practices or my eating habits, I'm probably not going to adhere or be compliant to that diet for long. You have to learn how to work with patients where they are and slowly try to get them to where they need to be. We need to give patients the opportunity. Now, a patient that does not take the oneness off of you, you have to own it, but we have to slowly work with you to help to tailor your interventions to get you to where you need to be. And those of us who are parents out there who have kids coming along, we know we've taught our kids sometimes some bad habits. So we have to try to begin to reteach. I see the difference in my first child and my second child, you know. With the first one, I was a little younger and I didn't know as many of the good habits or the importance. I was going through nursing school trying to get there. With the second one, I knew better, so I did better. But we can go back and relearn and reteach and try to do better.
Absolutely. The other thing that's real important for diabetics that helps to get your sugars under control is some sort of regular exercise. And again, it doesn't have to be, I'm going to go to the gym